Usually when we talk about a medical diagnosis, there's this expectation of precision, It feels almost like engineering.
Right, yeah. Like it's a math problem.
Exactly. You break your arm, the x-ray shows that jagged white line, and the doctor just points and says, there it is. Broken or not broken. It's clean.
It's binary. And honestly, we find a lot of comfort in that. We like things to be visible and easily categorized.
But step onto a bustling hospital floor, and suddenly that x-ray machine is just a tiny piece of a massive, chaotic puzzle.
Oh, absolutely.
You're looking at a landscape of patient care that is just constantly shifting. It is clinical, muddy waters. And if you don't have a reliable compass, you will sink.
And that's exactly why we're here today. We are handing you that compass.
We're looking at the foundational logic of nursing, not just the theory, but the actual mechanics of how to survive a shift and, of course, ace the NCLEX.
Yes, and it all starts before you even, touch a stethoscope.
Yeah.
If you have to understand the massive machine your patient is actually navigating.
All right, the healthcare delivery systems, because they dictate the reality of the care you can actually provide.
Let's look at levels of care first. We often hear primary, secondary, and tertiary, but what's that actually mean for a patient's journey?
Well, primary care is the entry point. It's the local clinic or the family doctor focusing on health promotion and disease prevention.
So catching the high blood pressure before it becomes a stroke.
Exactly. Then, if things escalate, they move to secondary care. This is where specialized expertise comes in.
Right. The patient has an acute medical problem, so they get a referral to, say, a cardiologist or a neurologist.
And then tertiary care is the absolute top of the pyramid. Highly specialized, life-threatening care that requires, advanced heavy-duty equipment.
Major trauma centers, intensive care units.
Or severe burn units, yeah. But the system housing all this care completely changes how a patient accesses it.
Totally. Like in a publicly funded universal model the Canadian System Essential Hospital and Physician Services are largely free at the point of care.
Because it's driven by tax funding.
Right. Contrast that with the U.S. system, which relies heavily on, private employer-based insurance mixed with these massive public programs.
And as a bedside nurse or a student studying for the NCLEX, you might wonder why you even need to care about the difference between Medicare and Medicaid.
Oh, but it matters deeply for your discharge planning.
It really does.
Medicare is generally for individuals 65 and older, or younger individuals with specific disabilities. Medicaid is a state and federal partnership primarily for low-income individuals.
So if you are creating a discharge plan for a patient on Medicaid, you have to realize they might not be able to afford that expensive brand-name medication you're enthusiastically teaching them about.
Exactly. The system's funding model dictates the reality of your nursing care plan, which brings us directly to the universal framework of that care plan.
The nursing process. ADPIE.
Yes, ADPIE. Assessment, diagnosis, planning, implementation, and evaluation. Think of ADPIE as your clinical operating system.
Assessment is gathering your raw data. Objective data like vital signs, and subjective data like the patient stating they feel nauseous.
Then we diagnose. But, and this is crucial, we aren't writing a medical diagnosis of pneumonia. The provider does that.
Right. Our domain is the nursing diagnosis. We identify how the patient is responding to the pneumonia.
So we diagnose the impaired gas exchange or the ineffective airway clearance.
From there, we move to planning, setting SMART goals. Specific, measurable, achievable, relevant, and time-bound.
Then implementation, which is the actual action. Administering the medication, repositioning the patient.
And finally, evaluation. Did the intervention work, or do we need to pivot?
I always picture the ADPIA process as building a house.
Oh, that's a good analogy.
Right. You cannot possibly build a sturdy roof, which is your implementation, without pouring a solid level foundation first.
And that foundation is your assessment.
Exactly. If your assessment is flawed, your intervention will just collapse. And the NCLEX will test your discipline on this constantly. They will give you a scenario and ask what you should do next. One of the options will be this brilliant textbook implementation. But you cannot click it.
Because you must always assess before taking action.
Always. Unless the patient is in immediate life-threatening distress.
I've always had a slight mental block with that rule when the environment is just pure chaos. Yeah. Say I walk into a room and a cardiac monitor is just screaming, red lights are flashing everywhere, alarms are blaring. My first instinct is to just silence the machine or fix the monitor wires so I can, think clearly.
That is such a common trap.
Doesn't the machine require an immediate intervention?
No, never treat the monitor. You have to assess the patient, not the machine.
Ah, right.
The pulse oximeter might be screaming that oxygen is at 70%, but when you look at the patient, they're sitting up, chatting, and breathing comfortably.
The probe just fell off their finger.
Exactly. If you rush to implement oxygen without looking at the human being first, you've completely bypassed the nursing process.
Wow, okay. So we have our single patient blueprint locked in. Always assess the human first. But what happens when you have like 5 patients who need that exact ADPIE process at the exact same time?
That is the reality of the floor. You have to know who gets seen first and who does what. The absolute bedrock of prioritization is the ABCs.
Airway, breathing, and circulation.
Right. If a patient's airway is compromised, nothing else matters. We also expand that to the ABCDE framework.
Which adds disability, meaning a rapid check of neurological status and exposure.
Meaning looking at the whole body for trauma or environmental issues. Beyond the ABCs, the CURE hierarchy is an incredible tool for sorting the chaos.
CURE. Right. C is for critical. These are immediate life threats like respiratory distress or acute chest pain.
U is for urgent, significant discomfort or safety concerns like severe pain or an elevated blood glucose level.
R is for routine. These are your typical scheduled tasks for stable patients, administering maintenance meds or helping with activities of daily living.
And E is for extras. Comfort measures, like giving a back massage or grabbing an extra blanket.
I've always struggled with this one prioritization scenario, though.
Let's hear it.
You have a patient with mild anxiety about a procedure, so that's an actual right-now problem, and another patient with dysphagia who has a risk for aspiration, which is a potential problem.
Okay.
Why does the potential problem win out over the patient who is actually suffering right now?
It all comes back to the biological mechanism of the threat. Mild anxiety is uncomfortable, but it's psychological.
Right.
Aspiration, even if it hasn't happened yet, is a direct mechanical threat to the airway. Fluid in the lungs leads to choking or severe pneumonia.
So the severity of the potential harm to the ABCs always elevates its priority.
Exactly. An airway threat, even a hypothetical one, always trumps a psychological comfort issue.
That makes total sense. Now, once you know who needs care first, you have to figure out who is providing it.
Delegation. As the RN, you retain ultimate accountability, but you must delegate to licensed practical nurses or unlicensed assistive personnel, also known as UAPs.
And for the NCLEX, just remember the acronym EET.
Yes, you cannot delegate evaluation, assessment, or teaching to a UAP.
The rationale there is really all about clinical judgment. A UAP cannot do an initial admission assessment or discharge teaching because those tasks require synthesizing pathophysiology, medications, and patient history.
You cannot delegate the intellectual heavy lifting. You also have to assess if the patient is stable or unstable.
Right, like a 3-day post-op patient is stable. Their routine vitals can be delegated.
But a brand new admission who just rolled onto the floor is unstable by definition. They require that comprehensive RN assessment.
So we've triaged our patients and delegated our tasks. But honestly, none of that pristine ADPII logic matters if we inadvertently spread an infection the moment we step through the patient's door.
No, it doesn't. We have to build an invisible shield.
Medical asepsis. Standard precautions apply to everyone. Hand hygiene, safe injection practices, meaning never recapping a used needle.
Never.
And wearing gloves if you anticipate contact with bodily fluids. But hand hygiene has some very strict biological rules.
Oh, absolutely. Alcohol-based hand sanitizer is fine for routine use, provided it's at least 60% alcohol.
But if your hands are visibly soiled, or if you are caring for a patient with C. diff, you have to use soap and water.
The mechanism behind C. diff is just fascinating.
It really is. It's a spore-forming bacteria, and those spores have an incredibly tough, resilient outer shell that protects them from harsh environments.
So the alcohol just sits on the surface of the spore.
Right. It doesn't penetrate or kill it at all. To get rid of C. diff, you need the mechanical friction of rubbing your hands together with soap.
And the running water to literally wash those armored spores off your skin and down the drain.
Layered on top of standard precautions are transmission-based precautions.
The easiest way to remember these for the NCLEX is to group them by how the pathogen travels. Contact precautions are for bugs that spread by touch.
MRSA, VRE, and C. diff. You need gloves and a gown.
Then you have the respiratory travelers, which fall into 2 distinct camps based on weight.
Droplet precautions are for pathogens that hitch a ride on heavy respiratory droplets when someone coughs. Influenza, pertussis, bacterial meningitis.
Because these droplets are heavy, gravity pulls them to the ground within about 3 to 6 feet.
That's why a standard surgical mask works if you are within that range.
But airborne bugs are the real ninjas. These are tiny, lightweight particles that don't fall to the floor.
They literally surf the air currents in the room and can linger for hours. Tuberculosis, measles, and varicella.
For these, a standard mask is useless. You need a fit-tested N95 respirator.
And the patient must be in a negative pressure room, which acts like a vacuum to keep those floating particles from escaping under the door into the hallway.
Speaking of all this gear, managing the personal protective equipment, the PPE has a very specific logic, especially when taking it off.
Doffing. That's where people make mistakes. You always remove the dirtiest items first.
Gloves come off first, then goggles, then the gown, then the mask. But the massive red flag strategy here is understanding that the most contaminated moment of your shift is right after you remove those gloves.
Yes. You must perform hand hygiene immediately after doffing gloves before you touch your face, your hair, or the door handle.
Think of it like peeling off a toxic hazard suit. When you take that gown off, you pull it from the shoulders and peel it inside out, rolling it into a bundle.
So the dirty outside never touches your skin or your scrubs. Question for you, actually.
Yeah.
If you have a patient with suspected TB, do you wait for the test results before putting on an N95?
Oh, absolutely not. If it's suspected, you immediately apply airborne precautions. You do not wait.
Perfect. Safety doesn't stop at infection control, though. Walking into that room means doing an immediate environmental scan.
Is the bed in the lowest position? Are the call light and personal items within reach?
And if the patient is confused or at high risk for falls, are we implementing alternative safety measures before jumping to restraints?
Restraints are an absolute last resort. If they must be used, they require a strict provider order.
And they must be tied to the immovable bed frame, never the side rail.
With a quick release knot. And we must assess skin integrity and circulation at least every 2 hours.
We also need to be prepared for acute emergencies, like seizures or fires. Seizure precautions mean having oxygen and suction equipment ready at the bedside.
And padding the side rails. For fire safety, the NCLEX loves the acronyms RACE and PASS.
RACE dictates your immediate actions. Rescue anyone in immediate danger, pull the alarm, confine the fire by closing doors, and extinguish if it's small enough.
And PASS is how you use the extinguisher. Pull the pin, aim at the base of the fire, squeeze the handle, and sweep from side to side.
So we've secured the room, we're wearing the right gear, and the patient is safe from immediate environmental hazards. Now we actually have to physically assess them.
The head-to-toe assessment is your baseline. We check vital signs, and we assess pain, which is widely considered the fifth vital sign.
But assessing pain or neurological status in a confused or developmentally delayed client requires a real shift in strategy.
Right, because if a patient has severe dementia, asking them to rate their pain on a scale of 1 to 10 is basically useless.
You have to rely on objective clinical skills. Are they restless? Are they guarding their abdomen? Is their heart rate suddenly elevated?
We also assess level of consciousness and orientation. We aren't just asking, do you know where you are? We are looking for an organized thought process.
And once we gather all this head-to-toe data, we have to communicate it effectively to the rest of the healthcare team.
SBAR is the universal language for this. Situation, background, assessment, and recommendation.
It strips away the fluff and delivers exactly what the provider needs to make a clinical decision.
And whatever we communicate, we must chart. Documentation is a massive legal responsibility.
But there is a very specific logic when it comes to incident reporting versus the medical chart.
Let's say a patient gets out of bed unassisted and falls. You assess them, they are stable, no injuries. You are required to write an incident report for the hospital's risk management team.
But do you write incident report filed in the patient's actual medical chart?
Never. The chart is an objective clinical record of the patient's health status.
Right.
You chart the facts. Patient found on floor, vital stable, neurochecks intact. The incident report is an internal administrative tracking document.
If you mention the incident report in the clinical chart, you inadvertently drag that internal document into the legal medical record.
Which completely changes how it can be subpoenaed. It's all about boundaries, much like HIPAA laws.
We protect the patient's privacy just as fiercely as we protect their airway. We only access the charts of patients we are directly caring for.
Exactly. Now, part of that baseline charting includes what is going into the patient and what is coming out. Let's look at the foundational fuel and waste.
Nutrition, hydration, and elimination. Nutrition screening is a day one assessment.
And the NCLEX will test your knowledge of therapeutic diets. Clear liquids are literally transparent.
If you can hold a glass of it up to the light and see through it, it's a clear liquid. Apple juice, broth, black coffee.
Full liquids take that a step further by including smooth dairy and opaque fluids that are liquid at room temperature.
Milk, pudding, strained cream soups. For patients who cannot swallow safely, perhaps due to a stroke, we implement swallowing and aspiration precautions during meals.
We keep them sitting upright for at least 30 minutes after eating.
And if they require an enteral feeding tube, like a nasogastric or NG tube, safety is paramount.
Before you ever administer a feeding through a new tube, you must verify its placement in the stomach with an abdominal X-ray.
Do not use the old air whoosh test with a stethoscope.
Right. It is not reliable.
Yeah.
Once you are feeding the patient, you have to monitor if they're actually digesting the food.
We check the gastric residual volume, or GRV, by pulling back the stomach contents with a syringe.
Facility policies vary, but generally, if you pull back a massive amount, say more than 500 milliliters, you discard it, hold the feeding, and notify the provider.
Because the food is just pooling in the stomach, increasing the risk of vomiting and aspiration.
But if you pull back a smaller amount, like 200 milliliters, you return it to the stomach.
And the physiological reason for giving that fluid back is critical. That residual isn't just leftover formula.
No, it's not.
It is heavily concentrated with the patient's own stomach acid, digestive enzymes, and critical electrolytes like potassium.
So if you throw that 200 milliliters in the trash, you are inducing a severe electrolyte imbalance.
And metabolic alkalosis. You have to keep those native fluids in the body.
Speaking of fluids, tracking hydration is practically an obsession on the nursing floor.
We look for signs of dehydration, like poor skin turgor or dark urine, versus fluid volume excess, like bounding pulses and edema.
You know what'll always seem counterintuitive to me, though?
What's that?
We track intake and output INO obsessively. We measure every milliliter of urine and write down every ice chip. Yet every textbook says that simply putting the patient on a daily weight scale is a much more reliable indicator of fluid status.
Oh, yeah.
Why is a basic scale better than our meticulous tracking?
Because human math is inherently flawed. INO charts are notorious for human error. A nursing assistant forgets to record a glass of juice, or a patient spills their water pitcher.
That happens all the time.
Right. But the scale does not lie, and it doesn't do bad math. The biological conversion is incredibly clean. 1 kilogram of body weight equals roughly 1 liter of fluid.
Oh.
So if a heart failure patient gains 2 kilograms overnight, they didn't eat 7,000 calories of pure fat while sleeping. They retained 2 liters of fluid.
The scale reveals hidden fluid retention instantly.
Exactly. Finally, we monitor the exit routes, bowel and urinary elimination.
For patients with Foley catheters, we keep the drainage bag below the level of the bladder to prevent backflow.
And we empty it when it's half to 2/3 full to prevent catheter-associated urinary tract infections.
If a patient has an ostomy, we empty the pouch when it's 1/3 full, so the sheer weight doesn't pull the adhesive off the skin.
And when we cut the skin barrier wafer, we cut it just 1/8 of an inch larger than the stoma.
The rationale there is a delicate balancing act. If you cut it too tight, you literally strangle the stoma's blood supply.
And if you cut it too loose, the highly acidic stool constantly leaks onto the surrounding skin, causing severe chemical burns.
It's incredible how much logic and precision goes into every single aspect of fundamental care.
It really is. We've walked through the massive delivery systems, used ADPIE to triage the chaos, built an invisible shield against infection, secured the environment, assessed the patient, documented our findings legally, and managed the intricate balance of fuel and waste.
You have the logic, you know the mechanisms behind the rules, and you have the strategies. When you sit down for the NCLEX, trust your preparation. You understand how these pieces fit together.
You absolutely do. But before we wrap up this deep dive, I want to leave you with a provocative thought that brings us right back to our opening hook.
Okay, let's hear it.
We spent a lot of time today talking about perfect textbook ADPIE planning. We talked about pristine discharge plans and carefully structured interventions.
Right.
But I want you to consider the social determinants of health. Think about a patient who lacks reliable transportation, who struggles with low health literacy, or who lives in a medical desert hours away from a pharmacy.
That's a huge issue.
How does your perfect, evidence-based discharge plan hold up in the real world when your patient literally cannot afford the therapeutic diet you prescribed, or doesn't have the bus fare to get to their follow-up appointment.
It completely falls apart.
It does. We want medicine to be a clean, precise X-ray. But true nursing requires stepping into the messy, complex reality of a patient's life outside the hospital walls. It's a reminder that we must always treat the whole human being, not just the condition they arrived with.
I couldn't agree more. Keep exploring the why, keep questioning the how, and keep advocating for your patients.
This podcast is brought to you by NCLEX Review Pro. Visit NCLEXReviewPro.com to explore all resources.
Step onto a hospital floor. Look at how clinical data is actually documented and reported, and that clear X-ray just shatters. We are navigating a communicative landscape that is deeply complex.
Very complex.
Today, we're examining the rigid frameworks that govern this landscape, specifically structured charting systems and standardized handoff protocols. The core tension we're unpacking is whether strict adherence to these standardized templates fundamentally protects patient safety, or if they inadvertently foster a rote, copy-paste mentality that degrades independent clinical judgment.
Right.
Single drop detail can be fatal. Standardized frameworks eliminate dangerous ambiguity.
And my concern is that our over-reliance on these rigid systems, especially in modern electronic health records, creates massive systemic blind spots. They encourage a checklist mentality that actually obscures the patient's true clinical narrative. It turns highly trained clinicians into, well, mindless data entry clerks.
Let's start with why we need that structure to begin with. Because the alternative is literal chaos.
Yeah, nobody wants diary entries on a napkin.
Right. When you have multiple disciplines, nurses, physicians, physical therapists, interacting with a highly acute patient over a 24-hour cycle, the sheer volume of clinical data is staggering. You cannot rely on free-flowing narratives to track a physiological decline.
Sure, I agree with that.
Data has to be rigorously categorized to be actionable. That is why nursing fundamentals demand we strictly separate objective data, measurable, factual findings like oxygen saturation or observed grimacing, from subjective data, which must be captured as direct quotes. Structured acronyms ensure no vital step is missed. It creates a closed, foolproof loop of continuity.
I completely agree that conceptually, structure is necessary. But we have to look at the human factors engineering here. The reality of clinical documentation on a busy medical surgical floor, where a nurse is juggling 5 highly acute patients, alarms are going off, and families are asking questions, it's entirely different from the idealized theory.
It's a high-stress environment, certainly.
Exactly. And what happens is that these templates don't guarantee critical thinking. They often actively replace it. The cognitive overload of the environment, combined with the rigidity of the electronic health record, it encourages clinicians to just blindly follow previous entries rather than performing their own independent assessments.
You're talking about the copy and paste phenomenon?
Yes, and we house concrete clinical audits demonstrating how dangerous this is. There is a well-known audit looking at wound care documentation. It revealed 3 different shifts of nurses mindlessly copying a chart entry that stated they had applied an ACE bandage to a stage 2 pressure injury on a patient's coccyx.
Which is anatomically impossible.
It is clinically absurd. You cannot wrap a compression bandage around a tailbone pressure ulcer.
No, you can't.
Yet, 3 consecutive licensed professionals signed their names to that intervention. That is the danger of blind trust in a standardized system. The first clinician made an error, maybe a typo or a misclick in a drop-down menu, and the rigid structure of the chart became a vehicle for propagating that error. The template created a false sense of security. The brain sees a filled box and subconsciously assumes the data is verified truth. Confirmation bias takes over.
It's an egregious error, sure, but I would argue that represents a failure of individual professional integrity, not a failure of the framework itself. We can't blame the guardrails when someone chooses to drive right through them. The core principle is that documentation must be objective, factual, accurate, and timely.
Right, but imposter syndrome is a powerful force for new clinicians. They see a previous entry and doubt their own independent assessment.
And that is exactly why the foundational rules of safe practice must be ruthlessly enforced. You chart what you observed, what you did, who you notified, and how the patient responded. You do not chart assumptions. Consider how the framework handles liability, for instance. If a patient falls, the The rules strictly dictate that you document the patient's condition, the assessment findings, and the interventions in the chart.
But you never document that an incident report was completed in the medical record.
Exactly. That is a critical rule. That the medical record is for objective clinical facts, not administrative liability tracking. A distinct separation protects the patient's clinical narrative from becoming a legal defense document. But, this cognitive overload you're mentioning doesn't just plague written charts, it bleeds directly into verbal handoffs too.
Oh, absolutely.
And this is exactly where standardized frameworks prove their worth. When a patient is crashing, time is tissue. This is why we rely on the SBAR communication method. It acts as a necessary cognitive filter.
It filters out the noise, yes, but does it filter out vital context in the process?
It filters the context down to what is clinically actionable. Take a classic clinical scenario. You are a nurse reporting on a patient who just returned from spinal surgery, and their blood pressure is plummeting. You don't start the call with a meandering narrative about the patient's anxiety that morning.
Well, no, of course not.
You start with the situation. Blood pressure is alarming at 85/46. Background. Admitted 2 hours ago post-spinal surgery.
Okay, so giving the immediate context.
Exactly. Then assessment. Patient is lightheaded and tachypneic, breathing rapidly at 28 breaths a minute with a heart rate of 112. And you end with a recommendation, suggesting a fluid bolus. That structure organizes panic into a targeted, highly efficient clinical intervention.
I won't argue against SBAR's utility in a clear-cut massive hemorrhage or a code blue. But medicine is mostly gray areas. What happens when the deterioration is subtle and the nurse doesn't actually know what the recommendation should be?
Well,
because the psychological barrier of that final recommendation phase is profound, particularly for newer clinicians.
But the protocol allows them to just ask the provider for a recommendation. They don't have to have the definitive diagnosis or know the exact pathophysiology.
In theory, yes, but human psychology doesn't work that way on a high-stress floor. Forcing complex, nuanced clinical deterioration into 4 standardized boxes makes a nurse feel like they have to solve the diagnostic puzzle before they are allowed to ask for help.
I see what you mean.
They think, I don't have a specific recommendation to offer, so I'm not ready to make this call. That hesitation delays vital communication. The rigidity of the acronym creates an artificial barrier, a feeling of being unprepared, when the most important thing they could do is just pick up the phone and say, something is wrong, I need you here.
My concern with relaxing that structure is that the alternative is usually an unstructured, panicked phone call that frustrates the receiving physician and delays care anyway.
Not always.
Often enough. The beauty of the framework is that it forces the clinician to gather all the necessary data before dialing the phone. It prompts them to check the latest lab results or, review current medications. It prevents that dreaded scenario where a physician asks a basic question and the nurse has to say, I don't know, let me go check the chart.
But again, you are treating the chart as this infallible source of truth. We just established with the ACE bandage example that the chart is often riddled with propagated errors.
Which is exactly why the foundational rules of nursing documentation actively fight against those shortcuts. Take pre-charting, for instance.
Oh, pre-charting is a massive trap.
Right. The rules strictly forbid pre-charting, documenting an intervention before it is actually performed. You cannot document a medication administration at 0800 if it's only 0730. Because the patient might refuse it or their blood pressure might drop, changing the entire clinical picture. The rules require real-time, chronological updates.
That's true.
Even on paper, errors require a single strike-through signed with initials, date, and time. No scribbling out. The entire system is designed around preserving a transparent, factual truth of the timeline.
Let's transition to how that plays out with patient education and pain management, because this is where the rigidity of the chart truly masks clinical reality. It reveals how these systems are often designed more for billing and audits than for actual patient care.
I'd welcome that discussion because pain management documentation is a prime example of why standardized, time-bound follow-ups are absolutely non-negotiable. If you administer an intravenous pain medication, the protocols rigidly dictate a documented reassessment within 15 to 30 minutes.
Right.
If it's an oral medication, it requires a 1-hour follow-up. This isn't arbitrary administrative red tape. It maps exactly to the pharmacokinetics of the drugs. The peak onset dictates the reassessment. The chart forces the clinician to physically return to the room and evaluate the physiological efficacy of the intervention.
Checking a pain score based on pharmacokinetic timelines is essential, absolutely. But let's look at how we document patient education, because that exposes the hollow nature of these checkboxes. The standardized chart requires the nurse to document that discharge education was provided.
And it requires objective proof of learning. You don't just hand a patient a pamphlet and check a box. The framework relies on methods like the teach-back technique or a psychomotor return demonstration.
Sure, for physical tasks.
Right. If you are teaching a newly diagnosed diabetic how to administer insulin, you have them demonstrate the physical action of drawing up the syringe and injecting it. You document that they successfully performed that specific psychomotor task. That is an objective, highly reliable data point.
It is a reliable data point for the psychomotor domain. I'll grant you that. But human learning isn't just physical mechanics. The chart almost entirely fails to capture the affective domain of learning, the patient's emotional readiness, their paralyzing fear of needles, or their actual health literacy.
But subjective quotes can easily capture affective states. A clinician can quote a patient directly saying, "I am terrified to give myself this injection, and I don't think I can do it."
But the templates don't encourage subjective quotes. They offer drop-down menus and checkboxes. A nurse checks a box that says education provided in lay terms or patient verbalized understanding. But that often masks a deeply flawed interaction. The patient might have nodded along simply because they were intimidated by the power dynamic in the room, or they were experiencing sensory deficits. Maybe they didn't have their hearing aids in, or they were just overwhelmed by the sheer exhaustion of being hospitalized.
I see your point, but
the nurse checks the box. The chart is legally compliant. The hospital can bill for the education. It looks perfect to an auditor, but clinically, it is completely hollow. The patient goes home terrified and confused and ends up back in the emergency room 3 days later.
But again, you are conflating poor clinical judgment with a flawed framework. The documentation framework explicitly warns against vague charting or using medical jargon. If a nurse teaches an exhausted, in-pain patient without their hearing aids and then checks the understanding verified box, that is a falsification of the clinical reality.
I fundamentally disagree that it's purely an individual failure. When a healthcare system requires a nurse to complete 150 mandatory charting fields per shift just to satisfy insurance requirements and accreditation audits, the system is actively incentivizing rote compliance.
Well, I think we are arriving at a valuable synthesis here. My position remains that rigorous, standardized frameworks, whether SBAR for communication or structured charting like SOPI, are the most effective defense against medical errors. They organize complex physiology into actionable data, ensure regulatory compliance, and provide a reliable, objective timeline that allows for seamless continuity of care across dozens of providers.
And my position is that these templates are only as safe and effective as the independent critical thinking of the clinician using them. Blind trust in historical charting, rote compliance with mandatory fields, and failing to recognize the limitations of structured communication can be just as dangerous to a patient as having no structure at all.
It seems we certainly agree on one fundamental point. Effective clinical documentation requires an incredibly delicate balance. A practitioner must utilize these structured frameworks to communicate efficiently and track data, while aggressively maintaining the intellectual independence to question the data in the chart right in front of them.
Precisely. You have to chart what you observed and what you did, but you have to treat the chart as a tool, not gospel.
It really highlights the immense complexity of what healthcare professionals are tasked with every single shift. Translating a living, breathing, deteriorating human being into a standardized two-dimensional record is a staggering cognitive challenge. There is certainly much more to explore regarding how healthcare systems can design these interfaces to better support human cognition rather than just optimizing for billing.
Without a doubt.
Which brings us back to the reality of the floor. You aren't just looking at a clean, white line on a black background. You're looking through layers of subjective quotes, objective labs, previous assumptions, and drop-down menus, trying to find the truth of the patient's condition hiding in the murky waters.
And the most important skill in that environment isn't knowing how to fill out the chart. It's knowing when the chart is lying to you.
This podcast is brought to you by NCLEX Review Pro, your trusted platform for smarter, high-yield NCLEX-RN preparation. Our motto, prep like a pro. Let the worries go. Visit NCLEX-ReviewPro.com to explore all resources.